Thank you all and a very good morning. Although a lot of radiology has been spoken by my previous speaker, friend Dr. Vishnu, I'll be talking about the radiological tools in the diagnosis of orbital tumors. I'll start with the basic principles of imaging modalities, go over to the approach essentially in the choice of modalities in dealing with the orbital pathologies, illustrate this with the clinical examples before I conclude. Now, CT, as we know, is a radiation-based modality, which is the images produced as a result of differential absorption and attenuation of X-rays to give contrast between different structures. We have an arbitrary scale, a Hounsfield scale, in which the zero is reference, zero is a water reference, and the densities go either below zero or above zero. Air is minus 1000, and calcium or bone could be anything from above plus 80. And not just this, we also can now produce images which are not just axial alone. We can produce sagittal, coronal, even curved images. This is a parasagittal image, CT angiogram, and volume rendered image. All is possible on CT. MR is a non-ionizing radiation-based modality in which the image is formed as a result of the signal produced by the interaction of the biological tissues with the magnetic field. I'll not go into the details. And what we produced is a set of images. To keep it simple, they are T1 and a T2 weighted image. The first one here is a T1 weighted image, which is much like a CT, in which the vitreous is dark. A T2 weighted image in which a vitreous is bright. And combination of these images is added to, say, a fat suppression, in which all fat around behind the globe and outside is suppressed to bring out the pathology like this. So one can do a lot of sequences to optimize your contrast and the diagnostic yield. So this is a busy slide just to tell you that various tissues behave differently on a T1 and a T2 weighted image, which helps us to characterize these tissues. Water is dark on T1, bright on T2. Fat is both bright on T1 and T2. Air, hemosiderin, and bone are all dark. That is because no protons take part in the magnetic process, so the signal is all dark. Hemorrhage, which is in the earlier phase, is bright on both T1 and T2, whereas if it's become late in a hemosiderin phase, it becomes dark. And melanin, MR, is important modality to diagnose a presence of melanin in a tumor, in which is bright on a T1 and dark on a T2, a typical MR signature. Now, PET scan gives us a functional or a metabolic information in which the glucose is labeled. A radio tracer, most commonly the FDG, the fluorodeoxyglucose, is labeled, which is injected. And FDG, like regular glucose, goes into the glycolytic pathway, but cannot proceed further, which is why it is trapped, metabolically trapped, and as it decays, it's picked up by the PET scanner and gives us the signal. Now, it has diverse oncological applications. However, it is limited by poor resolution and a lack of anatomical landmarks, which is why the PET and CT are both combined. PET gives us the functional information and CT gives us the anatomical information. Now, make no mistake, not all malignancies are FDG avid, or not all FDG avid tissue is malignant. Even the infected tissues do take up FDG. Now, to keep it simple, when we talk about the choice of approach, if we know the predominant pathology, whether it involves the globe or the orbit, we can then make a choice. So ultrasound is a excellent modality, which is the first modality of choice for evaluation of the globe. It's almost like an extension of a clinical arm. The strength is it's easily available, easy and freely available, but limited by poor penetration. If there is a pathology too far back behind the globe, you cannot assess the posterior extent of the globe. And of course, it's operator dependent. A pathology which is picked up by someone else, I may not be able to replicate, and vice versa. Now, MR is the next best modality after ultrasound if one has to do, because of the excellent contrast resolution and tissue characterization. RB is a typical prototype example which is used for staging of the retinoblastoma in diagnosis, staging, and follow-up. Now, for the orbital pathologies, MR, we've discussed about advantages. The disadvantages is that it has a long imaging time. Increased expense and limited availability is actually no longer so much of an issue. Multi-slice CT, again, as we discussed, is easy, quick, widely available. Strength is depiction of bone, whether it's involved, destroyed, intact, and calcium. However, it is a radiation-dependent modality. Uh, Now we realize that increasingly we are doing MR and CT both as a complementary tools for evaluating the pathologies. PET-CT, we have spoken about it, but essentially it is to look for a systemic disease. If the ocular abnormality has any other systemic source, and digital subtraction angiography is one modality which is now increasingly commonly used. Initially, we used to use it more commonly for the vascular malformations, now more for intraarterial chemotherapy in retinoblastoma. Now, we'll just, I'll describe a few examples. This is just to show a strength of ultrasound which shows a cystic lesion behind the globe so much better than CT does. So, advantage ultrasound. Now, this is just to show that the parasagittal image in a lid tumor will tell you how far behind the orbital margin a tumor would go. The excellent assessment for a preoperative information for a surgeon to do. And not just this, a Doppler can be done. A color Doppler tells you the prominent vessels that are coursing through the tumor, which gives an important insight into the vascularity. So expect bleeding. So, okay, another patient which was white reflex, a child who was not easily diagnosed, so suspected to be a retinoblastoma, but not quite sure. T2 weighted images do show what looks like a tumor here behind the lens. On T1 post contrast, there is barely a thickening, a mild thickening and slight contrast enhancement. We were still not sure. CT did not show any calcification, still at a loss. Ultrasound does show embryonic vascular channel, which is almost a giveaway, a diagnosis for a persistent primary hyperplastic vitreous. Now, bony destruction can be so much better seen on a CT in this patient of a retinoblastoma, a scalloping in this patient of a frontal sinus mucocele, osteoid osteoma, ivory osteoma, a dense compact bone. This information, which is so easily obtained on a CT, cannot be obtained on an MR. Again, a very ground glass looking appearance of fibrous dysplasia. This is one example in which a middle-aged woman was having a perioptic enhancement on MR, which could be anything actually. Although now, since you have a differential, a perioptic neuritis, sarcoid, or even meningioma. So the CT images do show what looks like a tram track, a diagnostic of a meningioma in an appropriate clinical setting. Retinoblastoma, dense calcification on CT are just not seen on MR. So understand the limitations of an MR also. While it is important to stage the pathology like retinoblastoma on an MR, you have to sometimes fall back on a CT to make a diagnosis. Fat can be picked up on a CT. So in a patient like this, we don't need to in fact do an MR. MR will only add to the cost. So once you know there are negative attenuation values in a preseptal pathology, typical location, young patient, so it's a dermoid, nothing else. Ultrasound in this patient showed what could be a tumor behind the globe, but we are not sure how far back, and you cannot define it that well. So MR comes handy. So in a typical middle-aged group, you see that there is expansion of a intraconal space with a large space occupying lesion causing proptosis. Optic nerve can be easily seen to be separate from this mass, displaced anteriorly, and a post-contrast you see a patchy enhancement which later became homogeneous. Diagnostic of cavernous hemangioma. Melanoma, as we discussed, MR picks up melanoma extremely well, and the bright signal on T1, dark on T2, this is a signature, MR, melanin signature for an MR. So on a T-weighted image, all that which is bright could either be a fat or a hemorrhage. So on a fat suppression image, here you see that everything else is suppressed, the fat is suppressed, and you see a bright tumor which is enhancing. Lymphangioma, again, MR picks up the bright hemorrhage here. Now again, as we just discussed in a previous case, anything which is bright on a T1 weighted image is either a hemorrhage or a fat. Now on a fat suppressed image, fat is suppressed, all that remains is a hemorrhage. So a fluid level, a hemorrhage in a lesion which is transcompartmental in a child in an appropriate clinical setting is nothing but a hemangioma. Retinoblastoma staging is another very good example when we use imaging, particularly the MR. T2 weighted image, a tumor which is almost completely occupying the globe. Post-contrast T1 shows the optic nerve enhancement, pre-chemotherapy. And post-chemotherapy, one can see that the optic nerve is still involved after 3 cycles of chemotherapy, which means that it's still not ripe for surgery. Now, last example of a lady with showing a plaque-like deposits behind the equator in a left globe, suspected to be a primary, but didn't know there was no leading history. So PET does show an area of uptake in the region of esophagus, a very unusual primary for ocular metastases. Patient did not complain of dysphagia. Patient first presented to an ophthalmologist with visual symptoms. So not just this, we also find metastatic disease in the lungs. So we know that the patient, which is the primary, we also know that the patient is not operable because of disseminated metastases. Now to conclude, we've seen that imaging helps us in understanding the diverse ophthalmic applications, and it's important to understand the strength and limitations of each of these modalities for its judicious applications. It helps us not just in accurate detection, diagnosis and follow-up, but also to contain the cost. With this, I thank you for your patient hearing.